everyone. So today we would discuss about the basic concepts and basic terms and concepts of mechanical ventilation, and I am Dr. Soumi Johnson. So the learning objectives would be to define ventilation, respiration, and define the terms such as transpulmonary pressure, etc. So let us discuss about the normal mechanics of spontaneous ventilation. So spontaneous ventilation is the movement of air into and out of the lungs, and the respiration is the exchange of oxygen and carbon dioxide between the organism and its environment. So, there are two components, the external respiration and the internal respiration. So, what is external respiration? It involves the exchange of oxygen and the carbon dioxide between the alveoli and the pulmonary capillaries, and internal respiration occurs at the cellular level and involves the movement of oxygen from the systemic blood into the cells. Now, apart from the primary respiratory muscles such as diaphragm, patients, when they have respiratory distress, they use accessory muscles of breathing. So, what are these muscles? For inspiration, they use scalene and sternocleidomastoids, pectoralis, and trapezius. And for expiration, we use rectus abdominis, external oblique, internal oblique, transverse abdominal muscles, serratus muscle, and latissimus dorsi. So, how does the normal mechanics of spontaneous ventilation occur? As we know, for air to flow, we have learned in our physics classes that a pressure gradient must exist between the two structures. So the lung volumes change as a result of gas flow into and out of the airways. So this is how does it occur? This is caused by the changes in the pressure gradient between the airway opening and the alveolus. Now, before going into the details of the pressure gradients, let us talk about the units of pressure. So the common units of measurements are 1 millimeters of mercury, which is equal to 1.36 centimeters of water, 1 kilopascals, which is equal to 7.5 millimeters of mercury, 1 torr, which is equal to 1 millimeters of mercury. So 1 atmospheres can be equalized to 760 millimeters of mercury and 1034 centimeters of water at sea level. Now, let us talk about the pressures and the gradients in the lungs. So, the first one is airway opening pressure, which can be also called as the mouth opening pressure, airway pressure, upper airway pressure, mass pressure, or proximal airway pressures. Now, the next one is pressure at the body surface, which is PBS, and which is equal to 0 or the atmospheric pressure, unless in a pressurized chamber or a negative pressure ventilator. So in the previous class, I had talked about the negative pressure ventilator, where the pressure would be decreased from 0. So it will become negative pressures. Now, when we say it is equal to 0, it is not actually equal to 0. As we know, it is 1 atmosphere. But for easy calculation, we consider that as 0. Now, the third one is intrapleural pressure. So, the pressure in the potential space between the parietal and visceral pleurae. So, between the two sections of the pleurae, there is a space, and the pressure in the potential space between these two spaces is called the intrapleural pressure, or which is denoted as PPL, P pleural. So that is about minus 5 centimeters of water at the end of exhalation, and about minus 10 centimeters of water at the end of inspiration. So that becomes more negative as the individual breathes in air. It is difficult to measure, so esophageal pressure is used to measure this intrapleural pressure. Now, the next one is alveolar pressure, which is PA or P alveolar. It is also called the intrapulmonary pressure or the lung pressure. So that is about +1 centimeters of water during spontaneous exhalation. It becomes slightly positive during spontaneous exhalation, meaning normal exhalation as we breathe in and breathe out, not on the ventilator. So when I say spontaneous inhalation and exhalation, it is how we breathe, you and me breathe. And it becomes minus negative say 1 centimeters of water during spontaneous inspiration. So there are four basic pressure gradients. What are they? The trans airway pressure, PTA, that is the pressure between the airway opening and the alveolus. So PTA is equal to P airway opening minus the P alveolus. Okay, pressure at the alveolus. So what does it represent? Why we should know about this particular pressure gradient? It represents the pressure gradient required to produce airflow in the conductive airway. So between the airway opening and the alveolus. This also represents the pressure that must be generated to overcome the resistance to the gas flow in the airways. So as we know, there is some resistance that is generated in the conductive airways. So only with this pressure gradient, uh, with this pressure that is overcome and the gas flow inside the airways. Now, the second pressure gradient is transthoracic pressure. So we said initially that there are four basic pressure gradients. The first one is trans airway pressure, PTA. The second one is transthoracic pressure. So that is the pressure between the alveolar space or the lung and the body surface. So that represents the pressure required to expand or contract the lungs and the chest. The third pressure gradient is transpulmonary pressure, PL or PTP, the pressure difference between the alveolar space and the pleural space. So that is the pressure required to maintain the alveolar inflation. So when we talk about the collapse of the alveoli or inflation of the alveoli, this is what we are talking about, the transpulmonary pressure. So this is also called the alveolar distenting pressure because this is the pressure that maintains the alveolar inflation. Now, the fourth pressure gradient is trans-respiratory pressure, that is PTR, the pressure difference between the airway opening and the body surface. So, this describes the pressure required to inflate the lungs and the airways during the positive pressure ventilation. So, this is very, very important when we talk about the positive pressure ventilation. So, that is the transthoracic pressure and the trans airway pressure. Now, this is the pictorial representation of all what we discussed till now. So you can see the airway pressure, mouth opening pressure, and the alveolar pressure, the airway alveolar distending pressure. So transpulmonary pressure, PL is equal to, P alveolar minus the P pleural pressure. And the transthoracic pressure is again P alveolar minus the body surface pressure. So that way we can explain how each pressure gradient helps our lung and the airways to move in and out the gas. Now again, explaining the mechanics of spontaneous ventilation and the resulting pressure waves. So in the first picture, we can see that during inspiration, the air flow in and due to the negative pressure that is created due to the contraction of the respiratory muscles diaphragm and the pressure is transmitted from the pleura to the alveolus and the chest is expanded and the air moves in. So as you see here, this is the pressure time graph. So we have the pressure becoming negative from -5 to -10 as we discussed, intrapleural pulmonary pressure is becoming from -5 from 0, and intrapleural pressure is becoming -10 from -5. So that is about inspiration. So what happens during exhalation? There is recoiling of the muscles, and the pressure becomes less negative, okay, and it becomes slightly positive. So since there is a pressure gradient again, the air flows out of the lungs to the atmospheres. Now, let us talk about the lung characteristics, which is also very, very important when we talk about the mechanical ventilation and the normal ventilation. So, what is compliance? Compliance is the relative ease with which the structure distance. So, if you take a balloon, we all blow balloons during birthday parties. So, the easiness to blow a balloon and make it big is the compliance of the balloon. So the alveolus is similar to, not exactly the same, but similar to these balloons. So the relative ease at which the structure distance is the compliance, in simple words. So in clinical settings, it describes the elastic forces that oppose the lung inflation. Now, what is elastance? So it is opposite to compliance. The tendency of the structure to return to its original form after being stretched or acted on by an outside force. So we all know about the elastic bands that we use in our clothes. So when stretch it and then leave, what happens to the elastic thread? So it will come back to the normal position. So that is elastance. So that is opposite to the compliance. So as you see in this picture, compliance is the measurement of change of volume that occurs when the pressure is applied to the system. So C is equal to delta V by delta P. So compliance is nothing but the change in volume per unit change in pressure. And, as you see here, if you measure the exhaled volume in the bellows, and you see how much is the volume which is exhaled, then we will know how much is the volume that is coming out. So the normal compliance is different than an intubated patient. So in spontaneously breathing person, it is 50 to 170 ml per centimeters of water, and an intubated person, if the patient is male, it is 40 to 50 ml per centimeters of water, because it is delta V by delta P. So it becomes ml per centimeters of water, and it can go up to 100 ml per centimeters of water if the lung is normal. In females, it is 35 to 45 ml per centimeters of water, and it can again go up to 100 ml per centimeters of water. For patients receiving mechanical ventilation, the compliance measurements are made during static conditions. So there are two types of compliance: static compliance and dynamic compliance. Dynamic compliance is when there is a gas flow, and static compliance is when there is no gas flow. So you have to have a pause. So static compliance is measured during the inspiratory pause. So what is static compliance? It is denoted as CS, which is exhaled tidal volume divided by the Plato pressure minus the end expiratory pressure, that is the PEEP. So tidal volume divided by the P Plato minus the end expiratory pressure gives you the static compliance. Now talking about the third lung characteristic. So till now we discussed about compliance and elastance. So the third one is resistance. So the gas flow, pressure, and resistance are described by the equation RAW. What is that? Is the airway resistance is equal to PTA divided by flow, where the RAW is the airway resistance and PTA is the pressure difference between the mouth and the alveolus. This we discussed in the previous slides as trans airway pressure. So the normal resistance is in unintubated patients is 0.6 to 2.4 centimeters of water per liter per second at 0.5 liters per second flow. And in intubated patient, it is similar to 6 centimeters of water per liter per second, or it can be higher. So during the inspiration, there can be airway resistance this way, because there can be different kinds of flows, such as laminar flow, transitional flow, etc. Now, how do we measure the airway resistance? It can be calculated as the PIP minus P plateau. Okay, so the PIP is peak inspiratory pressure, the maximum pressure that we achieve during the inspiration. So if I draw the graph, so it would be like that, inspiration. So this becomes the PIP. Okay, and if I give a pause, then this becomes the P plateau. P plateau. Okay. Okay. So let us move on. Let me erase this from the previous slide. Yes. Okay. All right. So so let us take an example of measurement of airway resistance. For example, flow is set at 60 liters per minute, and peak inspiratory pressure, which is the maximum pressure during the inspiration, PIP, is 40 centimeters of water, and P plateau is 25 centimeters of water. Now, PTA is therefore 15 centimeters of water. We had learned that PTA is PIP minus P plateau. So to calculate the airway resistance, flow, which is given at 60 liters per minute, is converted to, from liters per minute to liters per second. So 60 liters per minute is 60 liters divided by 60 seconds. So it becomes 1 liter per second. So then if you substitute the values, we get this kind of equation. Airway resistance is equal to PIP minus P plateau divided by flow. So 40 minus 25 centimeters of water divided by 1 liter per second. So that becomes 15 centimeters of water per liter per second. So the airway resistance becomes 15, which is very high. Now, the next lung characteristics is time constant. So now we discussed compliance, elastance, and resistance. So the fourth one we can say is time constant. So what is a time constant? A time constant is the length of time the lung units require to fill and empty. And this is a product of compliance multiplied by the resistance, and it is always equals the length of time in seconds required for the lung to inflate or deflate to a certain amount, to a certain percentage. So you can see different types of alveolus. Here it is normal. Here you have a very stiff lung, and you have a high resistance area here. So it depends upon the compliance and resistance of the system, how much time it takes to inflate or deflate the lungs. Okay, so if you draw a graph between the percentage of equilibration value and the time constants, you can see that, you know, uh, so here we can see the inspiratory volume and pressure, and this is the expiratory volume and pressure. So there are different percentages at which, see, 1 time constant, 2, 3, 4, 5, and 6 time constant. So that time the inspiration becomes 99.8% and all that. So 1 time constant allows 63% of the volume to be inhaled, and 2 time constants, how much it does allow? 86%. 3 time constant, it allows 95% to be inhaled. 4 time constant, 98 percentage, and 5 time constants will allow 100 percentage of the volume to be inhaled. Just a little bit about the types of mechanical ventilators, which we also described in the previous session. So we can divide them into negative pressure ventilator. We saw a lot of history about iron lung. Then we have positive pressure ventilation, that is the modern ventilators, and the high frequency ventilators. So that's all today. I'm I will come up with more videos again. So thank you for your patient listening.